Over the past decade, he has partnered with the Komfanoche Teaching Hospital and local faculty to help develop one of the first hand surgery fellowship programs in Ghana. His passion for mentorship, education, and elevating surgical capacity in Africa aligns deeply with the mission of AfroPRS, which makes his presence here today even more special. Please join me in welcoming Professor Brad Rockwell. You can all clap in the chat box. Prof, the virtual floor is yours.
All right, well, I'll start. So my name is Brad Rockwell. I'm a plastic surgeon from the University of Utah in the U.S. If anyone's looked at the U.S. map, we're in the western part, not as far west as California, but in the west. We're in where the Rocky Mountains are. Salt Lake's probably best known for hosting the 2002 Winter Olympics. And the 2034 Winter Olympics are going to come back to Salt Lake City. So it was actually snowing here yesterday. Utah is sort of known as an outdoor sport activity area: hiking, mountain biking, skiing, kayaking. And the University of Utah is in Salt Lake City, which is the capital of Utah. Okay, Laura, if you go to the next slide, please. So I have a 15-year connection with Komfanoche Teaching Hospital in Kumasi, Ghana. Our med school in Utah and the KNUST med school in Kumasi have a very strong 20-year relationship, and their faculty from both medical schools that go back and forth. Medical students go back and forth every December. We have between 2 and 4 KNUST medical students who visit Utah. And we formed an international plastic surgery collaboration that usually has 1 or 2 visits either to Ghana or to the U.S. each year. Okay, next slide. So we'll talk about breast reconstruction. Can I ask, has anyone who's here ever seen a breast reconstruction operation? One person. What type of reconstruction was it? Is that Valerie?
Inferior DF club.
All right. So Val, you saw a breast reduction. Is that correct? But have you ever seen breast reconstruction? So a woman that's had a mastectomy for cancer, have you ever seen a breast reconstruction to make a new breast?
I have seen one.
And what this is it LUM? What technique was used to reconstruct the breast?
Okay, I don't really know, but what was done was more of implants. She had implants after mastectomy was done.
Yes. Okay. So implant in the U.S., that's the most common method. There are implants that can reconstruct the breast, or usually tissue from the lower abdomen that can reconstruct the breast. So if you think of breast reconstruction, the basic requirements, we need skin and volume. So the mastectomy removes skin and the mastectomy removes the breast tissue. So if a woman had a mastectomy and then solely had an implant put in, there would not be sufficient skin to cover over the implant. So somehow we need to add skin and somehow add volume. When an implant is used, usually it's a 2-stage operation, and a tissue expander is put in first. That's essentially an empty implant that has a filler port, and a needle can be put through the skin into the filler port, which does not pop the implant, and saline is injected. Usually inject about 100 cc's, wait a week or 2, inject another 100 cc's, and the skin will gradually stretch. And then when a sufficient amount of skin has stretched, then the expander is removed and a permanent implant is placed. So a tissue expander first, breast implant second is one option. And we'll go through their other options using the patient's own tissue, which can all be done in one operation. All right, next slide. So here are the options for, obviously, no reconstruction has to be done. This breast reconstruction does not improve the woman's health. It does not lengthen her life. But one option would be expanders and implant, as we talked about. In the red font, second from the bottom, pedicle tram, that's the one that we've sort of used most of the time in Kumasi. Another operation is latissimus and an implant. So the latissimus does not have much volume. That's the muscle on your back. It connects to the arm near the armpit and progresses around the back. It's almost a mirror image to the pectoralis major muscle. So latissimus can supply skin, but then you need an implant for the volume. Another operation would be latissimus alone and then fat grafting. Fat grafting is liposuctioning fat from anywhere in the body, but most commonly from the abdomen. And then the fat is re-injected into a different site. You may have heard of a BBL, Brazilian butt lift. That's fat grafting to the buttock to make the buttock bigger. And the same process can be used to create volume in the breast. And if fat grafting is done, there would not be a need for an implant, but usually fat grafting would require several operations. There's a limit to how much fat will survive at each operation. So latissimus and fat grafting could end up being 3 or 4 operations. Pedicle tram is, I'll show you some slides later, that's one operation. And then there are more complicated operations that require microsurgery, and those are the free flaps. So a free tram, a free DIEP. Tram and DIEP are both muscles from the lower abdomen that include part of the rectus abdominis muscle. S-gap and I-gap are flaps from the buttock that are less commonly used. In the U.S., probably the most common method for reconstruction now is the DIEP, which is a deep inferior epigastric artery perforator flap. But that requires a microscope, microsurgery, usually ICU following surgery. And it's a complicated operation. We've tried one in Kumasi, but it unfortunately did not survive. It requires a fair bit of technical equipment, including the microscope and microsurgery instruments, good operating room light. So in general, we figured in Kumasi, a pedicle tram is the best option, giving cultural concerns, financial concerns, operating room time availability. And I'll sort of concentrate on that option. Okay, Laura, next slide. Also for reconstruction, there's immediate or delayed. So immediate reconstruction is done at the time of the mastectomy. Delayed reconstruction would be done sometime later after the mastectomy, maybe 6 months to a year. And all of the options that I mentioned on the previous slide can be performed at the time of the mastectomy or can be performed later. We found in Ghana, it would be very unusual to do an immediate reconstruction. Just about all reconstructions would be delayed. We found most women in Ghana who have a mastectomy will receive radiation therapy. And in general, reconstruction is done after the radiation has been completed. If there was a very early stage tumor, that woman would be a good candidate for immediate reconstruction. But we found in Ghana the staging isn't known until the pathology for the mastectomy is returned. And you don't want to do an immediate reconstruction and then find out it's a stage 3 or stage 4 tumor that requires radiation. So we found in Ghana, delayed reconstruction is the best option. All right, next slide, please. These are figures from about 10 years ago, but in the U.S., nationally, 1 out of 3 women choose reconstruction. 2 of 3 decide not to reconstruction. In my state of Utah, it was only 1 of 6. So the majority of women choose not to have reconstruction. Next slide. And these are the percentages: expander and implant, that 2-stage operation. These are figures from 10 years ago. About 80% of women who had reconstruction chose to have an expander and implant. 15% chose the pedicle tram, and 5% had a free flap, usually the DIEP flap. Now the figures that DIEP has become much more common. Okay, next slide. And here are the operating room times. Mastectomy alone, and these are figures from the US, but mastectomy alone usually takes about 1.5 hours. Woman would stay 1 night in the hospital. Doing an expander at the time of the mastectomy adds an hour to the operating time, but really doesn't change the recovery. You can see lower down, the tram flap is about a 5-hour operation, and the recovery usually 4 to 7 nights in the hospital. Free flap is 10 hours, also 4 to 7 nights in the hospital. So the surgical involvement of the tram or free flap increased significantly over a expander and implant. We also found in Ghana the cost of an expander and the cost of the implant are significant and make it so most women who want reconstruction cannot afford to have an expander and implant as their reconstructive options. And so the pedicle tram flap is a 1-stage operation that seems to work best. Okay, next slide. This is just the anatomy of the chest. It shows the blood supply to the breast. For reconstructive purposes, the important vessel is over on the right. If you can see my mouse, is internal thoracic artery. That's also called the internal mammary artery. This courses posterior to the sternum. And then at the costal margin, the lower edge of the ribs, it becomes more superficial and enters the rectus abdominis muscle, and it progresses down the abdomen, and that's the blood supply to the rectus abdominis. The rectus abdominis is included in a tram flap, and so the rectus abdominis with the skin and fat of the lower abdomen create a tram flap that can be used for reconstruction. Next slide. And here's just some innervation to the breast from supraclavicular nerves and medial intercostals and lateral intercostal nerves. Next slide. And again, just anatomy, the underlying musculature. You can see the breast tissue there, the tail of Spence, which is breast tissue that needs to be removed with a mastectomy. And then the axillary lymph nodes are shown in the axilla. Underlying the breast is the pectoralis major muscle, and then below that, rectus abdominis and the serratus anterior. And you can see the latissimus in the very posterior part of the photo. Okay, next slide. For reconstructive purposes, the hardest part of reconstruction is creating symmetry. As you're aware, with time, with pregnancies, the breast will develop ptosis or droop. All the methods we have to reconstruct a breast do not produce droop in the breast. So to get volume equal between the two sides is fairly reliable, but to get true symmetry out of clothing usually requires a lift or mastectomy on the uninvolved breast, or if the woman would like a reduction, breast reduction on the uninvolved breast. and then reconstructing the involved breast at a smaller volume than original. Okay, next slide. Yeah, so this is just looking at implants and tissue expanders. Technically, this is the easiest option, but it is a two-stage procedure. One, putting in the tissue expander, and then in the OPD, stretching the skin, and then a second operation to remove the expander and place the permanent implant. Implants are also not good forever. All implants eventually will develop a leak. It could be 15, 20, 25 years before they do, but usually if a woman has an implant, we say that at some point in your life, you'll probably need a second operation to remove a leaking implant and place a new one. Next slide. Yeah, we can skip this. We talked about immediate and delayed. So the next slide. So tissue expanders come in different shapes. You can choose an expander shape based on the shape of the opposite breast. But basically they stretch the skin. The shape of an expander makes a small difference, but not a huge difference. So really any type of expander will serve the purpose. Next slide. So this is looking at one-stage operation immediate. So at the time of mastectomy, performing the reconstruction, I say it's best not to radiate the reconstruction. So if radiation therapy will be given, better to perform the mastectomy, then give radiation therapy, and then do reconstruction. So stage 1 and stage 2 breast cancers in general do not need post-op radiation therapy. Those women would be candidates for immediate reconstruction, but it can be difficult to tell if a woman's tumor is stage 1 or 2 before the mastectomy is performed. There are ways to do it with a very good pre-op mammogram or with a pre-op MRI. We found in Ghana that's it can be difficult to stage the woman pre-op. So I don't think any immediate reconstructions have been done in Ghana. Next slide. That's just looking at implant types. The outer shell of implants are really the same. They can be filled with saline or with silicone. There's a little different feel to feel the breast. The woman on her chest would not notice a difference. Silicone has similar consistency to breast tissue, and from a cosmetic standpoint, that's felt to be better. But saline-filled implants are pretty close to silicone implants. So they're both good options. Textured surface implants have largely gone away several years ago. There was a concern for a very rare type of lymphoma cancer. So most implants now have a smooth surface. And then as you can see, some are round, some have an anatomic shape. MRI studies have shown that round implants and anatomic shaped implants really have the same shape once they're in the body. The implants adjust to the anatomy of the woman. The implants don't create a different shape. Next slide. All right, let's skip this. We'll get more into trends. So this is looking at exchanging an expander for an implant, but I don't think you would see that much. So we can go to the next slide. We'll get to the tram flap part. So radiation, in general, radiation and implants don't mix well. The radiation changes the tissue. So if radiation is given, an implant can be used for reconstruction, but in general, it's not a good choice. Next slide. And as I say, getting symmetry between the two breasts is the hard part. The uninvolved breast may have a good contour. The reconstructed breast may have a good contour, but the contours don't match each other. So typically, to get good symmetry, a procedure on the uninvolved breast will be necessary. That's usually either a lift, which is called a mastectomy, or a breast reduction. And a breast reduction makes the breast smaller, but it also produces a lift as the normal part of the breast reduction. Next slide. Yeah, next slide. So this is now going away from implants and looking at our own tissue. Go next slide. That's just a summary article. So using the woman's own tissue, either a latissimus or the tram flap from the abdomen, there's good longevity. You can vary the size and shape. The volume of the reconstruction depends some on how much tissue the woman has in her lower abdomen, but also using a tram flap, the woman to some degree gets an abdominoplasty or tummy tuck as a side benefit of the surgery, and it's also possible to do it in a single stage. Next slide. So that's just the tram flap. It has a good blood supply, and so the side benefit is an abdominoplasty to make the abdomen smaller. Next slide. We'll skip this. That's just gives the anatomy of the tram flap. Okay, so here's a photo. Uses the superior epigastric artery is the continuation of the internal thoracic or internal mammary artery. When the artery passes distal to the costal margin, the name changes, although it's the same vessel. And the vessel courses through the rectus muscle. You can see in the picture in the lower abdomen, some of that flap is superior to the umbilicus, some of the flap is inferior to the umbilicus. And in that area, blood vessels from the superior epigastric branch off and go through the muscle and then continue going through this fat and up to the skin. So by taking the rectus muscle, blood supply is preserved to the fat and skin overlying the muscle. All of that tissue that is shown is not supplied. So in general, the skin and fat that's directly over the rectus muscle will still have blood supply, a small amount lateral to the rectus muscle, and a very small amount on the opposite side of the midline overlying the opposite rectus muscle. But one rectus muscle is used, the other rectus muscle is preserved, and then the remaining fascia in the abdomen has to be closed to prevent a post-op hernia. Okay, next slide. So there's the zones that on the left-hand drawing, what's called zone 1, that the left rectus muscle will be used in this case, and the skin overlying it is used. So all of zone 1 has good blood supply. A small amount of zone 2 and a small amount of zone 3 will have blood supply. And then the rest of that skin and fat is removed, but it's discarded. If we only took zone 1 and then closed the abdomen would look odd. So essentially, by removing all of that skin and all of the fat beneath it, the abdomen can be closed, and in essence, the woman has an abdominoplasty or tummy tuck as a side benefit. Okay, next slide. And we'll skip that one. That gets into the next slide. That gets into sort of more complicated factors. Let's skip that one. That's sort of at the very late resident level. It is possible to take both rectus muscles if a woman had a bilateral mastectomy, or if she was very thin and needed a large, if there wasn't much fat in the abdomen and she needed more bulk than what a unilateral tram would give, both muscles could be taken. It was found that the muscle loss in the abdomen was very significant. Women had chronic abdominal pain because of decreased core muscle strength. So bilateral tram, not recommended now. Next slide. And we'll skip this. That gets into very advanced, if there are problems with the flaps. Next slide. Potential complications can be fat necrosis. That's the most common complication. That's if the blood supply to the fat that's included with the flap is insufficient. Fat necrosis, some of the fat can die. Usually that's identified clinically. Post-op, the fat will liquefy, and then you see a sort of fatty exudate that comes through the incision that can become infected. If the fascial closure in the abdomen is not good, an abdominal hernia can develop. With any surgery, hematoma infection will result. And then just from a cosmetic standpoint, size mismatch I explained there's a limit to how much skin can be included with the flap. The volume that's replaced is whatever fat is beneath that blood perfused skin. So there's a size limit to the volume of a tram flap, and that size may be smaller than the woman's uninvolved breast. If so, the breast is reconstructed at whatever size the abdominal flap will allow, and then a breast reduction would be performed on the uninvolved breast to create symmetry. Next slide. And we'll skip this. The free tram flap, I think, would in general not be a good option in your setting. And we'll skip this one. The free flap part, yeah, I'll skip that one. That may be the end of the talk. So I'll just show you. So the DIEP, it takes the same skin as a pedicle tram, as you can see on the left lower abdomen. But instead of using the blood supply from the superior epigastric, it uses the deep infraepigastric, which is a branch of the sort of femoral artery in the groin. You can see on the drawing on the left upper, on the left lower side of that drawing, it's a little hard to read, but it shows the deep infraepigastric coming off essentially the femoral artery, and it enters the muscle. And so you can take the deep infraepigastric with just the perforators, preserve the muscle. The perforators of the vessel that come out of the muscle go through the fat into the skin. So the DIEP preserves most of the muscle. It's still functional and innervated, but it's a technically much harder operation to perform. Next slide. And we'll skip this one. So that looked at morbidity to the abdominal wall. The DIEP gives less insult to the abdomen by preserving more muscle. The more muscle that's preserved, in general, the more risky the operation, the blood supply to the operation is. Next slide. Yeah, let's skip all this. So this is taking flaps from the buttock. This is when a DIEP is not an option. Then the surgical involvement gets more. Next slide. I think these would not be appropriate in your setting. Yeah, I'll skip that one. And we'll skip that one. Those are just taking flaps from the abdomen. And skip that one. You can also take inner thigh flap based on the gracilis muscle. And latissimus is a good option. As I said earlier, it does not have a lot of volume. So if a latissimus is used, you either need an implant to give it volume, or you need to do fat grafting over 2, 3, or 4 separate operations. Next slide. Yeah, that's the anatomy of the latissimus muscle. Next slide. And that it takes all of the latissimus muscle with an island of skin and the fat that's between the skin and the muscle. There's not much fat there, so the volume is not great. And the muscle itself is very flat, so the muscle does not have much volume either. Next slide. Let's skip all this. We're going to get short of time. So there is a way to reconstruct the nipple also. That's usually not done at the time of the reconstruction, but 3 to 6 months later. Yeah, next slide. And it just uses local tissue to create the nipple, and then either a skin graft to create the darker tissue of the areola, or tattooing. Next slide. Yeah, next slide. I think that's probably the end of the talk. Okay. So that last slide that's our hospital, University of Utah Hospital, and with the mountains right behind the hospital. Well, thank you, everyone. Went through that quick. Hopefully it was all understandable, but the stimulus at Confo Noce to do breast reconstruction was actually started by the medical oncologist. And he said that a number of women who had breast cancer would not allow a mastectomy to be performed because they didn't want to lose their breast. And so he was hoping if the plastic surgeons could perform breast reconstruction, more women would be willing to have a mastectomy to treat their breast cancer. Are there any questions I can answer?
Thank you so much, Professor Rockwell. That was incredibly insightful and an inspiring session. Please, anybody that has any question, no question is too big or too small. So you can either type it in the chat, or you can just unmute your mic and ask the question. Okay, I have a question, actually.
Yeah.
Okay, so in what circumstance would you choose to do a tram flap over a DIEP flap? Like, what are the circumstances that you choose one over the other?
Well, to do a DIEP, there has to be a good operating microscope, very good microsurgery instruments. The surgeon has to be competent in microsurgery. Sewing 2-millimeter blood vessels together under a microscope, and usually you need ICU post-op for several days to monitor the flap. If the surgeon does not have microsurgery training, it's not a good option. A pedicle tram flap is very reliable. It's a technically complicated flap, but nowhere near as complicated as a DIEP. So we found in Kumasi Confu Noche, the pedicle tram is the best option.
Thank you. There's a question in the chat. Someone is asking, why is implants more expensive in Kumasi compared to the United States?
Oh, I don't think implants are more expensive there than in the US, but I mean, in the US, an expander maybe costs $1,000 and an implant would be close to another $1,000. So with us, our medical insurance will pay for the cost of an implant. But my impression is in Ghana, usually the implants I think come from South Africa, and just the cost is more than a lot of women are willing to pay.
Okay, thank you. I have another question. You mentioned that majority of 1 in 6 women in Utah have would choose to undergo a breast reconstruction surgery. So majority of women would not want to have the reconstruction done. And I wanted to know what the reasons are in your setting as opposed to in Ghana, if they are the same or if they are peculiar ones to the US.
No, I would guess the reasons are the same. It's surgical fatigue might be a good description for it. Just, the women have gone through a mastectomy, maybe had chemotherapy, maybe had radiation. And after all that, then they think, do I want to go through another operation for breast reconstruction? And a number of women will decide no, they've been through enough medical procedures and they'd rather just like to go on with their life and not add more surgical care and recovery to their life. So it's a individual or social reason. It's not a medical reason.
Okay, my last question. How do you approach breast reconstruction in patients with significant comorbidities, like someone that has diabetes or someone who is obese? How do you approach breast reconstruction in that kind of situation? Do you treat the comorbidities first, or those do not interfere with the surgery itself?
Well, they interfere, so it might be that if there's significant comorbidities, a free flap would not be an option. That may make an expander and implant a better option because it's surgically less involved. But yeah, I mean, hopefully the comorbidities are optimized before surgery, so their diabetes is under good control. I don't think you have many people who smoke, but in the US, there are people who smoke, so we ask them to stop smoking. But yeah, so you want to maximize their medical well-being, and then tell them that, those factors will still have an impact on their surgery and their risk of infection is higher, and do they want to go ahead with those increased risks?
Okay, thank you. There's one last question in the chat box. Valerie is asking, do women who have completed breastfeeding still need tissue expanders? In brackets, I'm assuming the expansion of mammary glands acted as a tissue expander.
Well, so if I'm understanding the question correctly, I'd say with the mastectomy, I mean, just about all the skin and all of the breast tissue are removed. So after a mastectomy, the skin lays flat on the pectoralis muscle. Even if a woman has breastfed and had a ptotic breast before the mastectomy, there's no redundant skin after the mastectomy. So think before a mastectomy, there'll be different shapes and volumes of women's breast. After a mastectomy, most women will look the same on the operated side. There'll just be tight skin right on the pectoralis muscle. So an an implant by itself, still not an option, even if women had very tonic breasts before surgery.
Okay, thank you. We're trying to keep the time, but someone has their hand up. Valerie, I think you can unmute and speak.
So you mean in a woman who does not have breast cancer? Is that correct? Yeah. So she just has a tonic breast? Yeah. So that's I can give you the answer. That has it's a separate issue from this talk. So the talk was women who have had mastectomy where the breast is removed. So if a woman has a tonic breast, usually the best option is just a lift or what's called a mastopexy. So that preserves all the breast volume, but it moves the breast from lower on the chest wall to higher on the chest wall. An implant will increase the volume, but usually I think most women who are breastfed may not want more volume to the breast. They just want a sagging breast elevated to a higher position on the chest. And then it's just a mastopexy with no implant.
Okay, thank you so much, Prof. I think that's all the questions for now. Thank you so much for sparing your time and your energy to speak to us. We are really, really grateful. And thank you, everybody, for making our time to join the webinar. If you don't mind, we would like to take a group picture. If you could turn on your cameras just for some seconds for us to take a group picture, everybody. Okay. Can we do the picture? Hi, everyone. Can we kindly turn on our videos, please, if that's possible? Thank you, Alvin. Okay, we are out of time, so yeah. Thank you, Raphael. Who again? Valerie, Ada, Praises, Estelle, Bosibori. If you don't mind, we'd like to take a group picture. Thank you so much. Okay. I think we're ready to go. All right, everybody say cheese.
Okay, cheese.
Okay. Thank you.
All right. Well, thank you, everyone. That was great.
Thank you very much. That was very exciting.
All right. Everyone go into plastic surgery. It's a great specialty.
Yes, I approve.
Yes. Okay.
Okay.
Thank you. Thank you.
Thank you, everyone.
All right.
The meeting is
Bye.
officially. Thank you. Goodbye.
Bye.